Dr. Surya sir, who invited me to deliver a talk on this challenging subject, challenges in ataxia management. See, when you talk about ataxia, the challenge starts there itself for the patient, for the doctor. As soon as a patient of ataxia comes to your clinic, I'm not talking about acute and subacute ataxias, where you will have a number of causes and patient, many of them will improve because of some intervention. I'm talking about those patients who develop chronic ataxia, means most of them will be hereditary ataxias. So what are the challenges? As I said, the challenge starts in the beginning. Some clinician years back wrote that the diagnosis of chronic ataxia is itself challenging. It's a big task to reach to a diagnosis in chronic ataxia cases. So you can see here, management of cerebral ataxia. This has been taken from UK paper. How many types of clinicians would be required? Clinicians, other uh, disciplines would be required to manage a case of chronic ataxia. So, you know, when you are working in a hospital, especially in a government hospital, you refer a case to ENT or you refer a case to some cardiac department. It will take days for the patient to reach to particular clinician. I'm sure the difficulty is less in private sector, but in the government sector, you will not get appointment for 3 months, 4 months, just to show a case in ENT department. You have referred because you have referred to cardio, no appointment for 6 months. So it's a difficult thing. So it is itself a challenge to collect these many people under one umbrella. You need genetic counselor, you need the clinicians, you need the wheelchair clinic and several other people. You need the physiotherapist, you need occupational therapist, social worker, many people. So you need a kind of clinic, you need a kind of umbrella or a roof where everyone is sitting below that and trying to manage these cases of chronic ataxia. Not moving? Yes. Okay. So ataxia, it does not come alone. Although there are causes where there will be just ataxia. We call it point mutation disorders, where you will have just cerebellar features. But you remember, you must have read earlier, there are many ataxias which will have features well beyond just cerebellar symptoms. So there will be many kind of non-motor symptoms, I will say. And some patients will have neuropathy, some patients will have some cardiac problem, like if you remember Friedreich's ataxia. Some will have a prominent spasticity. So there are several things, kind of spectrum, where you'll have all kinds of things, not only cerebellar symptoms. So you need to manage all that. There is definitely a percentage of patient, lesser percentage of patient, which will just have cerebellar features. And not only that, if this symptom persists for years, then you will have to face other things: immobility, pain, some fatigue, respiratory distress, social isolation, and over a period of time, patient will have difficulty in swallowing, and in general, several of the patients will become bedbound. So several things need to be taken into consideration. And falls. Imagine a 60-year-old man or 50-year-old man falling and developing some fracture. And in that scenario, many will be just confined to bed for years. Dysarthria, I already told. Dysphagia. Ocular symptoms. Cognition. Several of the hereditary ataxias or chronic ataxias will have impact on cognition. And we have already published about involvement of cognition in various spinocerebellar ataxias. Autonomic features, various systemic issues, you know that, how difficult it will be to manage. So as I said, ataxias have many phenotypes. Even one disease will have different phenotypes. Like if you talk of type 2 ataxia, some patients will have Parkinsonian phenotype. Some patients will have prominent cerebellar signs only. So again, to diagnose them will be difficult. And once you have diagnosed, you take them for kind of rehabilitation, that will further be difficult. Motor symptoms, non-motor symptoms, and again, need to be taken into consideration. Lot of non-motor symptoms, as is true for Parkinson's disease. Same thing will happen with these patients as well. So everything is required to be taken into consideration. And again, since I am a clinician, will definitely tell you, look into a treatable cause and look into a treatable kind of symptom where you can actually do something. You may not be able to do everything or anything for many of the symptoms. Like if you talk of ataxia, there is no medicine. For this symptom, there is no medicine which may improve the patient. Unless you have a treatable cause, like you have drug-induced ataxia. You remove the drug, patient will improve. But for somebody having ataxia because of some genetic disorder or idiopathic disorder or whatever reason, those patients will not have any medication to improve their symptom of ataxia. So if we talk of various ataxias, say hereditary ataxias, till today, there is no medication which has proven that it will help them. There are small trials of various trials on mouse models. So as I say that if you are a mouse with ataxia, you may improve. But we are not mouse. We are human beings, not likely to have the same impact as shown in those mouse studies. So there are few things which have actually worked. People talk of riluzole, which works. Again, unproven, very few trials, and many of trials which have come later, not helping. So there are no disease-modifying therapies. But not to forget, again, there are some patients which will improve, specifically episodic ataxia patients. Type 27, SCA type 27B patients will show some improvement with acetazolamide or 4-aminopyridine. So those patients, again, as I say, to diagnose them is difficult. 27B is specifically difficult. Episodic ataxia you may think of, but 27B will be difficult. Very strange kinds of course. Initially, they will have some episodic pattern, and after few years, maybe 10 to 12 years, they will have a progressive kind of illness. So this is very specific kind of ataxia. We have published it from our center, and initial part of illness, it does show improvement with acetazolamide and kind of drugs. So again, not to forget some E deficiency. Ataxia with vitamin E deficiency, if diagnosed early, will show improvement, but not if you have diagnosed late, it may not show improvement. Coenzyme Q10 deficiency, replace, patient may be helped. Immune-mediated ataxias, and these are ataxias which will have acute, subacute kind of course, not the kind of illness which I am talking, chronic ataxias. This again a type 12 paper, which tells you from our center only, and which tells you that probably propranolol is helpful in doses of up to 240 milligram. This trial has been done by me only. Up to 240 milligram per day, continued for at least 8 weeks, has shown improvement in patients with type 12 ataxia, which is the most prominent symptom in these patients. These patients are not ataxic for years. Like you will find patients, people who are seeing these cases will notice that some of the patients will not develop ataxia for 20, 40 years. I remember a patient of 83-year age. Historically, he had ataxia since 35-year age. Sorry, he had tremor for 35-year age. But ataxia appeared after 80 years of age. So for 40 years, he was not having any kind of ataxia. So this is a variation or heterogeneity seen in type 12 cases. So that patient only required management for tremors, not for ataxias. So you need to find out which is the symptom which is troubling most and may be acted upon. Many of the symptoms you can't help. So again, talking about rehabilitation, specifically for hereditary ataxia, it works well. But of course, what is the challenge? It requires a long session, repetitive sessions. So after some time, when there is not much improvement, people now are looking for something which improves fast, which works fast. Everyone is in a hurry. So these patients are also in a hurry, although having ataxia. So if there is no improvement in few weeks, they will disappear. They do not stick to the rehabilitation therapy advice to these patients. This is also a big challenge with these patients. So it takes months. So they disappear after some time. And also, they know the history. In the same family, there was yet another case. They know after these many years, they will become bedbound. So why to do all this? So I visited a place in Maharashtra, only Buldana district. There is a village where every second, third house has type 3 ataxia. In every house, there are 2 to 3 patients. So what kind of management they want? Their wish was just to have a kind of rickshaw trolley, which they may use it for movement. And the other thing was that they wanted to know, as soon as one person is born in the family, उनके सर पे एक तलवार लटक जाती है, उनका कहना था। तो हमें उसी दिन बता दो कि बाद में अटैक्सिया होगा या नहीं। They are right, it can be done. But how ethical it is to tell the family or the child that you are going to have SCA3 once you grow up. This question was asked to me by an engineer in the same village. He said, had I known that I will develop this kind of ataxia, I would have not studied. I would have not invested money in study. So there are questions which need to be answered. These are big challenges actually. So this is another strategy which works well. But again, how much time they stick to this kind of approach, you don't know. After some time, most of the patients disappear. So I'll skip all that. So why outcomes fade? The challenge again. Sometimes what you have applied is not enough. The intensity is less. I will say that you have given lesser doses. The thing I was talking about, poor long-term adherence. People do not want to stay for longer time. You know that not much improvement is going to take place. After a few weeks, they have noticed that there is not much improvement, they run away. So people often ask me, how do you run ataxia clinic? So it is actually very difficult. Even for doing trials, it's difficult. Type 12 patients are easier to manage because most of them are walking. As I said, that they develop ataxia in later part of illness, most of them. So they are walking, they keep coming. And also they are literate people. Most of them belong to the one community, which is very literate community. So they keep on coming. Again, there is nothing like booster therapy, limited drugs, very limited drugs. I told you about there is no drug which can improve ataxia actually. And moreover, people who are in villages or smaller cities, no rehabilitation services. I visited a village in Bihar. There was a health camp organized by one politician in Bihar who is no more now. I'm talking about 25 years back. I went there and found there are n number of patients with cerebral palsy, even a ataxic variant as well. There was no rehabilitation service. Only one physio person came to me after third day of the camp. He met me because I was asking everyone, is there a physiotherapist? Is there some rehabilitation service in this area? So third day, somebody came to me. And he told me that in 100 kilometers, there is nobody giving physiotherapy or rehabilitation services. So this is the scenario, a big challenge. So again, emphasizing that don't forget treatable causes. I keep emphasizing because if you miss those cases and don't treat early, they will become chronic and will not show the same improvement which you are expecting in early part of illness. So with this, I finish my talk. Rehabilitation is the cornerstone of specifically chronic ataxia management. Best evidence supports intensive, coordinated, repeated training, which is again a very challenging thing. Outcome measures should include gait, balance, falls, activities of daily living, and participation. So again, this is very challenging because adherence is a big problem. And the various video game based approaches do help, again require adherence. People disappear after some time. Compensatory strategies remain essential, especially in advanced diseases. Long-term maintenance is the real clinical challenge, which I am emphasizing and saying off and on. This is my movement disorder team. I have taken up yet another challenge to organize a conference on ataxias. And this is another challenge. You have to find the speakers and the audience as well. So this is a challenge thrown to me. This is being organized on 16th and 17th of May at AIMS, New Delhi. Thank you so much. I invite all of you to.
Thank you. Thank you, Dr. Achal, for a very comprehensive talk, especially focusing on the challenges in ataxia management and giving some solutions. So the session is open for questions, comments.